This lecture is on the radiology of dentoalveolar trauma. So the first question you might be asking yourself is, who cares? Wouldn't dental trauma be obvious clinically? Well, yes, but this assumes the ER physician performs an intraoral exam, which they don't always do. And in the setting of trauma, the oral cavity may not be top priority. Also, even if the injury is noticed by the clinician, radiology may help guide the physician in taking the appropriate next clinical step, which may be a referral to a dentist oral surgeon. And finally, there are complications of dental trauma that are not visible clinically, but are readily seen radiographically. So first, I will discuss the types of dentoalveolar trauma, which intuitively includes dental trauma and alveolar trauma. Dental trauma comes in two forms, fractures and displacements, whereas alveolar trauma typically results in fracture. For each type of trauma, I will review the hallmark image findings and important associated findings. And finally, I will review the key points of the lecture. All right, a brief review of dental and periodontal tissue anatomy. The tooth has three main tissues: enamel, dentin, and pulp. And remember that enamel is essentially completely inorganic. The dentin is also inorganic, being about 70% mineralized. Does not have cell bodies, but does have cell processes that extend from the underlying pulp. And these processes within the dentinal tubules, they're called, can transmit changes in temperature and pressure and osmotic gradients into the pulp and can be sensed by pain. So when those dentinal tubules are exposed, the patient can be symptomatic. The pulp, of course, has a lot of pain fibers, lymph tissue, a lot of blood vessels, and of course it would be painful if that tissue was exposed as well. The periodontal tissues are comprised of gingiva, cementum, which is a very thin lining of tissue on the surface of the root that is not seen radiographically. There's the periodontal ligament that connects the cementum and the alveolar bone. And there are a number of cells and cell types within the periodontal tissue. And then there's the alveolar bone that houses the teeth, and the alveolar bone is part of the maxilla or the mandible. So with the anatomy in mind, let's review the common classification system for dental fractures. It's also called the Ellis classification. Type 1 involves just a fracture of the enamel only. Type 2 is the enamel and dentin. Type 3 involves the enamel, dentin, and pulp. And type 4 will involve the crown and the root. And so type 1 and type 2 are referred to as uncomplicated dental fractures. And that's because there's really no emergent treatment that's needed if only the enamel or dentin is involved. Now, type 2 might be painful. That exposed dentin can be very sensitive. And it may need to be covered with just some composite for aesthetics or for the patient's comfort, but it doesn't need a root canal or an extraction. Type 3, on the other hand, because the pulp may be involved, that's going to require most likely a root canal and possibly an extraction. And that is termed complicated. And then isolated root fractures are not technically part of the Ellis classification system, but I would consider an isolated root fracture as a complicated dental fracture. This slide shows diagrammatic representations of the fracture types that I just discussed. And I got these images from this website, dentaltraumaguide.org. It's a really great website. And it goes into detail and explains the terminology of all different types of dental trauma in both kids and adults. One thing I want to point out is the type 4 fracture, the type of fracture that involves the crown and the root, may involve the pulp, as it does in this case, but it also may miss the pulp, as it does in this case. Either way, I would put this in the complicated dental fracture, because when a fracture goes below the gum line, that puts it at risk for restorability. It may or may not be restorable, and it needs to be seen by a dentist quickly. On imaging, a dental fracture presents as a sharp, well-demarcated, and linear loss of typically coronal tooth structure. And the differential includes decay, erosion, and attrition. Erosion is caused by typically acidic substances that demineralize the tooth. It could be either substances that are consumed or in frequent vomiting. And attrition is caused by a mechanical destruction, either from grinding teeth or chewing on pens, but it's a mechanical destruction of tooth structure. So a cavity tends to have more rounded as opposed to linear margins, and you will likely see the underlying demineralization as well. Erosions tend to be on the lingual surfaces. That's where the consumed or the liquid acidic substance would be. And that's not a common surface affected by trauma. Attrition will often involve opposing teeth. So there'll be a defect on, let's say, the upper tooth, and its opposing lower tooth will have a very similar defect, and that suggests attrition as opposed to trauma. You may not be able to see pulpal involvement, particularly on CT, but I would say when in doubt, just suggest the possibility of it and recommend dental referral. Case 1, this patient presented after trauma to the midface, and you can see that there's a relatively linear loss of tooth structure involving the left maxillary central incisor. There's loss of the enamel, and there's probably a little bit of loss of the dentin as well. And there's no decay on this tooth. There's no demineralization. There's no obvious periapical radiolucency. And so in the setting of trauma, this appearance most likely represents a type 2, because it involves the enamel and the dentin, type 2 dental fracture of the left maxillary central incisor. Case 2, this patient also had trauma to the midface. You can see there's multiple kind of comminuted nasal bone fractures. And then take a look at the maxillary central incisors. On this slice, it looks like there's linear loss of coronal tooth structure, but if you look closely, you still have all three layers of teeth. You have enamel all the way around each tooth, and you have the dentin. You might be getting a little bit of the pulp chamber on this image. This is perfectly symmetric. So what's going on here? Is this bilateral symmetric dental fractures? No, this is just the way the coronal slice is cutting the teeth. And dental trauma wouldn't be bilaterally symmetric, and you still have the enamel. So the only thing you could potentially be missing would be a type 1 dental fracture of just a little bit of enamel, and that is really an insignificant miss anyway. So if you see this, but the enamel would never extend down to here. All right, I mean, the enamel is this thin layer along the tooth surface. So this is not a type 1 fracture involving enamel. This is simply the way that the coronal slice is cutting the image. So don't call this a fracture. So case 3, I'm just going to go ahead and tell you that this patient had trauma to the upper lip and jaw and had numerous dental fractures of the maxillary teeth. But the reason why I'm showing you this image is because of this. So this is an embedded tooth fragment in the substance of the upper lip, and this may not be visible clinically. And this can cause a lot of problems for the patient: poor wound healing, pain, and infection. So this is one opportunity where the radiologist really can be helpful, because this needs to be pointed out so the provider can really irrigate this area well, try to go after this piece of tooth and remove it to save the patient from complications down the road. Okay, this slide is important because it led to a lot of confusion for me, and that's why I wanted to try to explain it here. In MSK radiology, we hear the terms subluxation, dislocation, and avulsion all the time, and these words have slightly different meanings in dental trauma. So let's first talk about the MSK terms. So subluxation is a displacement of a bone from its opposing articulating surface with at least some residual portion that remains in articulation. I like to think of it as an incomplete dislocation. Whereas a dislocation is when the bone is displaced and is no longer articulating with its opposing surface. And then an avulsion is often used to describe when a tendon or tendon and bone detach. In dental terms, subluxation means something different. Subluxation means there is tooth mobility without displacement. And if you think about it, if it hasn't moved at all, how is it mobile? It has to do with injury to the periodontal ligament and maybe severing of some of the periodontal ligament fibers, and maybe a little bit of widening of the periodontal ligament space without displacement of the tooth itself. Luxation in dental terms is really similar to the MSK terms of subluxation. So a luxation of a tooth means it has moved within the socket. It could either move apically, kind of into the bone, it could move out laterally, it can move any which direction, but it remains at least partially in the socket and within the oral cavity. So luxation is kind of similar to subluxation, again, in MSK radiology terms. And then an avulsion is when the tooth is totally out. So keep in mind the dental term subluxation for mobility without displacement. And again, radiographically, it's going to be tough for the radiologist to make that diagnosis, although sometimes you can see a little widening of the periodontal ligament. And then luxation, again, that should be fairly obvious, both clinically and radiologically. And then avulsion in radiology, you'll just see an empty socket. Here are some diagrams that depict the terminology I was just talking about. Here's subluxation, again, no displacement of the tooth, but mobility, maybe some widening of the periodontal ligament space. Extrusion, you have coronal displacement of the tooth itself with some widening of the periodontal ligament space. And intrusion, the tooth goes apically, that is towards the apex of the root, and you'll get loss of the periodontal ligament space. And then lateral luxation, you get a displacement of the tooth in one direction or the other, and it's often accompanied by a monocortical fracture as well. So before I show cases, I want to just review the imaging appearance of tooth displacement. In a subluxation, there may be widening of the periodontal ligament space, or it may be subtle or undetectable. A luxation, again, is a displacement of the tooth within the socket, and one type is extrusion, which is a coronal displacement of the tooth, and you'll see widening of the periodontal ligament space, particularly widening at the apex. A lateral luxation, which it says lateral, but it means it can be in any direction, buccal, labial, lingual, and you'll see a displacement of the tooth as well as usually a monocortical buccal or lingual plate fracture that allows the tooth to move in that direction. And then intrusion, you'll see impaction fracture at the apex, and you'll really see a loss of periodontal ligament space around the apex. And then, of course, with an avulsion, you'll see an empty socket. Case 1, this is a panoramic radiograph of a patient who sustained trauma to the upper teeth. You can see it looks like there may be a fracture of that right maxillary lateral incisor, and if you squint closely, you might be able to see the widening of the periodontal ligament space involving the right maxillary central incisor right there. And clinically, this patient looked like this. So this patient indeed had a fracture of that right maxillary lateral incisor and had a mild luxation or displacement of that right maxillary central incisor. This is the same patient post-treatment. You can see there's been application of a dental splint bridging the right maxillary central incisor, and you usually want to get at least 2 stable teeth on either side of the luxated tooth. Case 2 also resulted from trauma to the upper teeth, and this panoramic radiograph shows an empty socket right here, and the tooth next to it looks like the right maxillary central incisor has widening of the periodontal ligament space at the apex, and the tooth appears to be coronally displaced. And the left maxillary central incisor also appears to be coronally displaced, and in addition, the post is going in that direction and the root canal filling is going in that direction, and they should be more in line than this. So I also suspect a root fracture involving that tooth. And clinically, this is what the patient looked like. So pretty significant injury. Here's case 3, trauma to the upper lip after a bike accident. And on this panoramic radiograph, I think the most notable thing is this right maxillary central incisor. So look at these 2 central incisors here. They're usually kind of symmetric, and the one on the right kind of looks like it's a little bit sideways. Maybe it's missing some tooth structure right here. It's tough to tell what's going on, but it doesn't quite look normal. And this is what the patient presented with. So laceration to the upper lip and a dental fracture involving the right maxillary central incisor. And again, there's space between the 2 teeth here, and that right maxillary central incisor was rotated. So there was a luxation as well as a dental fracture in this case. Same patient post-treatment, showing improved alignment. You can see there's no longer a space between the maxillary teeth. Case 4, this patient fell and hit her upper front teeth, and this is tough. I mean, this was obviously not the greatest radiograph, a lot of stuff going on. The one thing you should look at in cases of trauma is look at the occlusal plane, and then look at these maxillary teeth, how far down they go. I mean, it is true that the maxillary teeth overlap the mandibular teeth, but that seems a little bit excessive. And patient clinically looked like this. So this case exemplifies the fact that sometimes you can underestimate the degree of dental injury on panoramic radiographs. Now, of course, this would not be missed clinically, but you don't want to call something normal when the patient actually looks like this. Case 5, this patient was punched in the nose, and you can see here on this coronal section CT, there's increased periodontal ligament space at the apex of the right maxillary central incisor, and on sagittal section of that same tooth, there is a labial plate fracture and possibly some labial displacement as well. And this looks very similar to the diagrams we looked at. So there's increased periodontal ligament space at the apex and a monocortical labial plate fracture with labial luxation. Cases 6 and 7 both show the same finding, and that is empty sockets. These indicate an avulsion in the setting of trauma. And I've been told that avulsed teeth should be accounted for either clinically or radiographically, and that if you can't account for them, then you should get a chest x-ray to make sure it wasn't aspirated. I'm not sure it needs to be that hard and fast of a rule. You know, I think if the patient is walking and talking and doing okay, maybe you don't need that. You could say something like, if there is concern for aspiration, a chest radiograph may be indicated. Something like that. But again, the finding for an avulsed tooth is an empty socket. In this case, also looks like it probably has an alveolar fracture as well. Now I'm going to talk about alveolar fractures. You may hear this term or have seen this term, but I want to make sure it's clear what it is and what it's not. This is a fracture involving the buccal and lingual cortices, and it may or may not involve the tooth socket. It does not extend to the inferior border of the mandible, because then it would be a mandible fracture. And in the maxilla, it does not extend to the nasal floor or the pterygoid plates, because then it would be some kind of maxillary fracture, and probably a Lafort if it extends to the pterygoid plates. It is also not a monocortical fracture with tooth displacement. That is typically just considered to be a luxation, and monocortical fractures kind of go along with a luxation. So this is a monocortical fracture with a luxation down here, and shown here is an alveolar fracture involving both the buccal and lingual cortices. Alveolar fractures can be difficult to detect on panoramic radiographs, particularly in the anterior maxilla. And on CT, the hallmark is, of course, the buccal and lingual plate fractures, but you'll often see a block of bone that may contain teeth all moving in the same direction. Here's an example of a maxillary alveolar fracture, and has those features that I mentioned on CT. You've got fractures going to the lingual and buccal plates, and you can see there's kind of like a block of bone here that contains tooth, and there's slight displacement of the whole block. Here's another case demonstrating the same finding. You've got fracture of the buccal and lingual plates. This is of the mandible. It does not extend to the inferior border, and again the block of bone and teeth kind of move as one big segment. So in summary, the treatment of dental fracture varies by type, and you want to try to determine if the pulp is involved. So if the pulp is involved, then it's at least a class 3 dental fracture, also called a complicated fracture, and you should be seen by a dentist within about 24 hours, because usually a root canal or possibly an extraction will be needed. So any fracture involving the pulp or any root fracture, even if it doesn't involve the pulp, should be termed complicated, and prompt dental referral should be made. Ideally, avulsed teeth should be accounted for clinically or radiographically, and you can just say if aspiration is suspected, a chest radiograph may be indicated. As you saw in the cases, it's not easy to exclude injury on panoramic radiograph, so I wouldn't even try necessarily. I mean, there are subtle signs that we saw, but in almost every case, the clinical appearance looked much worse than the radiographic appearance. It's really important to check the soft tissues for fragments of teeth or bone. This is something that the clinician may not see, and any remaining tooth fragment can be a nidus for infection and poor wound healing later on. And then with dental injuries, there are often multiple injuries, so be aware of satisfaction of search.